Welcome back. We're talking about a second part of diabetes medication, insulin. Something nobody likes to use. I hate the word. They think they fail because they end up on insulin. Unfortunately, that's sometimes part of the progression of type 2 diabetes. You have limited beta cell. You tried everything you can to try to keep that curve. You save your beta cell, but everything failed. Eventually, you have not enough insulin production in the body. You have to take insulin. Doesn't mean you fail something, but they mean you have a disease, unfortunately, that progressed to that point. You don't have enough insulin there to handle your glucose. You see that usually when your fasting sugars are very high. You see it when your A1C is really high, 9–10%. Your doctors say, unfortunately, you have to start insulin. And what is insulin? What does it do? What kind of insulin? We have 40 different kinds. You have to understand how they work together and what is the right insulin for the right person. To understand that, we will show you graphs of how these insulin work. There's something called action profile of insulin. We do through a clamp study. You can measure how does that insulin work, and you see the curve, and you understand from that curve how long that insulin is staying in my body, when does it peak, so it will tell me when should I take it, how long does it work, so how long do I expect it to control my glucose? It is important to know that with every insulin, to understand how they work and to adjust your doses and food and activity based on that. In insulin in general, we have short-acting, long-acting. Why we have that? Because normal physiology, our normal pancreas produces insulin all the time on a regular basis. If we eat, we don't eat. 50% of our insulin produced on a regular basal rate, even if we fast all day. Then we got these peaks to cover our meal, depending on how many times we eat. And that's around another 50%. In order to replace insulin production in normal physiology, just like what happened with the normal pancreas, we have to give this long-acting insulin 50% of the dose, and the other 50% has to be given with meal. We'll show you a picture of how they insulin, and we come back and we talk how we choose which insulin based on that. So understand insulin, there's the older version of insulin. We have the human old insulin, regular. And regular works differently than newer insulin. It probably stays in the body around 6 hours, especially if you have renal failure, and larger doses stay longer. It takes probably 1.5 to 2 hours to reach its maximum, so it has to be given 1 hour before meal in order to get the best benefit of it, which is make it difficult to use. The risk of high sugar early, then low sugar late is a problem. So we need a better insulin, and that's what we looked for, the newer one, the analog. You see why we use the analogs? And we have 5, 6 of these newer insulin, as you see here, lisproglulazine, aspart, and a few others. They work within minutes, and they don't last as long. They're out of the system 2 to 3 hours. The nice about these analog, you can give them with the first bite of the meal, and they still work as good, which is a lot more convenient for patients. And they're out of the system in 2 hours, and so they know how it works. We have a super fast one called FIASP, work within seconds, and this one actually, the super fast one, you can give it after meal and it will still be effective. This is important for parents who are concerned, I don't want to give my kid insulin, he decided not to eat, and also for people taking care of elderly patients who say, I'm afraid if I give my mom insulin, decide not to have breakfast, her sugar will drop. The newer FIASP will help you decrease that risk by taking it after you eat. On the long-acting insulin part, we have the older one, MPH, which is part of these mixed insulin, 70-30, 75-25, 50-50. The MPH is not a true basal insulin. It doesn't really stay 24 hours and a peak in 7 to 8 hours. Has to be given twice a day. And you have to worry. If you take it in the morning, you have to worry about 2 o'clock in the afternoon hypoglycemia. And if you take it at night, you have to worry about hypoglycemia at 2 o'clock in the morning. So you have to adjust the dose based on that. So we need a better insulin. As we see here, maybe not great, accurate representation. We have glargine Lantus, the first one, true basal that came out, last 24 hours, especially with 0.3 units per kilogram. Detamere, levemir was the second one that came, maybe a little shorter action, especially on the lower doses. In type 1, you may have to use them twice a day. In type 1, you use them once a day, but there's no peak, and the risk of hypoglycemia is better. But again, we needed better insulin. So we have a newer insulin, more concentrated and lasts longer. And this is Toujeo and Tresiba. So in order to talk about insulin, we have to understand the reason we use combination of long-acting, short-acting, because that's what the normal pancreas is doing. There's two different ways of approaching insulin. One in type 2 diabetes. If you are on pills and maybe injectables like GLP-1 analogs and you still have high sugars, you need to start insulin. Usually you start with a basal insulin at bedtime or in the morning once a day, 24 hours. And then if needed in the future, you start adding quick-acting one after the other. You can go from one before dinner to one before breakfast and dinner, then eventually one before breakfast, lunch, and dinner. So you don't go from 0 to 4 shots in type 2 diabetes. You go gradual. But in type 1 diabetes, at the same day of diagnosing type 1, you have to be in 4 shots a day. You have to be just like normal physiology, long-acting, 24-hour, plus the short-acting. And you have so many options. Sometimes you say, well, I like Humalog, not Novolog. There's really no big difference. The newer one, Fiasp, I show you, it may be faster, better acting, but we usually like to be on the analog, the faster one, because we can give them with the first bite of the meal. That will reduce the risk of hypoglycemia, low sugar risk and problem, and you can move them with the meal. So the idea, take one shot 24-hour of glargine or levemir or Toujeo or Tresiba. We prefer the newer one because it's long-acting and they be more flexible and they're concentrated. And then you move your fast-acting insulin with your meal. So I'm going to have a breakfast at 9, next day I'm going to have breakfast at 7. On the weekend, I'll wake up at 1. It doesn't matter with these insulin. You can move the fast-acting with your meal. If you eat twice a day, you only take 2 shots a day. If you eat 3, you take 3. You eat 5, you take 5. But with the long-acting, you always stay the same dose. There's 2 scenarios that happen. After you take insulin, your 4 shots, you're not controlled, knowing how your insulin works, and you still have very uncontrolled sugar. You start going higher to a point where we're becoming more insulin resistant and you're taking more than 150 units of insulin a day. We have one insulin that works in that scenario called Humulin RU500, concentrated, 5 times stronger, smaller volume, easy to absorb. It can be given 3 times a day. This would replace both your quick-acting and the long-acting insulin. One insulin that's only given to patients who are severely insulin resistant who needs 150 to 200 units a day and is still not controlled. But you have another type of uncontrolled diabetes with insulin called the brittle, where you are taking the same shot every day, but one day your sugar dropped to 50, next day it goes to 300. With the same shot, same activity. Now your absorption is different. We can spend an hour talking on why that happened. One of it, you have to change location of the shot. You have to move around to prevent damage to the skin because that will affect absorption. It's also related to the insulin itself. There's something called intrasubject variability. That means insulin doesn't work the same way every day because of problem with the insulin itself or the problem with the storage. There's a problem with the needle, temperature, technique, location, how much damage do you have to your skin. All these factors you have to put it in. If you factor all of that and fix all of that and you're still uncontrolled, you look at diseases. Do I have a kidney problem, liver problem? Do I have problem with absorption of food? Do I have gastroparesis? Do I have malabsorption disorders? We look at these things and you still fix them and you still have a problem with the absorption being brittle, response to insulin, then you have to consider insulin pump. And we'll have a whole talk on insulin pump because insulin pump provides something that the injection does not do, which is adjusting basal rate and giving different ways of delivering boluses for better sugar control, but that's mainly for brittle, difficult diabetics.